The benefits of long-term participation in physical activity are well documented. From reduced risk of chronic conditions such as obesity to increases in measures of psychological well-being, it is no secret that the beneficial effects of physical exercise are extensive. Having said that, it is also no secret that many of us fall short of the recommended 150 minutes of moderate physical activity each week. Because of this, helping people to modify their behaviors that pose significant health risks is one of the biggest challenges that health practitioners today face. However, there is good news. Much research surrounding behavior change demonstrates that not only can motivational states be influenced, but motivational states can fluctuate in response to how a practitioner delivers information. To begin, theorists have proposed that readiness for change is a crucial mediator of behavioral change. Specifically, a trans-theoretical model of behavior change, or in more simpler terms, the stages of change model, posits that health behavior change involves progress through 6 stages of change: pre-contemplation, contemplation, preparation, action, maintenance, and termination. Successful progression through these stages leads to action, where the necessary steps to achieve change are undertaken. It is important to note, however, that relapse is considered an important stage in the change process and is used as an opportunity to learn about sustaining maintenance in future. Stemming from this model, a counseling method coined motivational interviewing was developed. So, how exactly can the motivational interviewing process motivate people to change from a well-established sedentary lifestyle to a lifestyle of regular physical activity? We'll begin by going over the spirit of motivational interviewing. The spirit of motivational interviewing is described as collaborative, evocative, and autonomy supportive. That is, a collaboration between the client and the practitioner when making decisions. For example, a collaborative practitioner may acknowledge their client's current level of fitness when devising a plan for increasing levels of physical exercise. An evocative practitioner will evoke reasons from the client to change their sedentary lifestyle that comes from the client themselves. And an autonomy supportive practitioner will support the client's autonomy by acknowledging that it is the client who is in control of their behavior and not the practitioner. An authoritative therapeutic style is described as confrontational, educational, and authoritative. That is, assuming the client has a flawed perspective and approaching the client in an imposing and coercive way, assuming the client lacks insight into why they need to engage in regular physical activity or behavior change, and authoritatively instructing the client to make the necessary behavioral changes. This therapeutic style is likely to yield disappointing results for both the client and the practitioner when it comes to motivating the client to change their behavior, or in this case, get off the couch. It is important to remember, as the pioneers of motivational interviewing once said, using motivational interviewing strategies in the absence of the spirit of motivational interviewing is ineffective. Now that we've covered the spirit of motivational interviewing, let's discuss what it looks like in practice. The implementation of motivational interviewing occurs in 2 phases. Phase 1 is focused on building motivation to change, and Phase 2 is focused on strengthening that commitment to change. Phase 1 utilizes basic interaction techniques and skills that are used early and often in the motivational interviewing approach. These basic counseling techniques assist in building rapport with the client and establishing a therapeutic relationship that is consistent with the spirit of motivational interviewing. What are these techniques, you might ask? They are represented by the acronym OARS, O-A-R-S. Open-ended questions, affirmations, reflective listening, and summary reflections. Working our way through the acronym, open-ended questions are the opposite of closed questions. Closed questions usually evoke a limited response such as yes or no. Open-ended questions, on the other hand, invite the client to do most of the talking and tell their story in their own words without leading them in a specific direction. Not only do open-ended questions allow the opportunity for the practitioner to learn more about the client, they also allow the client to freely explore issues surrounding their need for change, fostering a sense of autonomy. Putting yourself in the client's shoes for a second, I want you to take note of how you feel when I provide you with an example of each type of question. First, a closed question. Are you aware there are other ways to stay active besides running? Now, an open-ended question. I understand that you don't like the idea of running, but you do like swimming. Can you tell me a little bit more about that? Not only do open-ended questions elicit an answer more elaborate than a yes or no, but it also allows the client to explore their motivations for change and provides the practitioner with a better understanding of the client's motivations and potential barriers for change. Next letter in our acronym, A, affirmations. Affirmations are most effective when the client's strengths and efforts for change are noticed and affirmed. These acknowledgements can take the form of compliments or statements of understanding and are super helpful in building rapport between practitioner and client. One example of an affirmation that a practitioner could provide could be, quote, I understand that going from an inactive lifestyle to that of an active one is difficult. It is courageous of you to consider this strategy for improving your health, end quote. The best thing about affirmations is that they are true. Next up, R, the utilization of reflections. Reflections or reflective listening involves rephrasing a statement to capture the implicit meaning and feeling of a client's statement. This encourages exploration, helps the client understand their motivations, and is useful in reinforcing that desire for change. For example, if a client were to say, quote, I am too overweight to reach my goal of 150 minutes of exercise per week, end quote. To rephrase this, a practitioner may say, quote, you are worried that your weight will impede your ability to exercise, end quote. Reflective listening is meant to close the loop in communication to ensure breakdowns do not occur between client and practitioner. Finally, S, summaries. Employing the skill of summarizing is similar to that of rephrasing. However, summaries go further in that they ensure mutual understanding of the discussion so far whilst highlighting discrepancies between the client's current situation and future goals. For example, to summarize, a practitioner will relay all that they've heard from the client and confirm that they have understood correctly. Summarizing helps to ensure that there is clear communication between the speaker and listener, whilst also providing a stepping stone towards change. On to phase 2, strengthening that commitment to change. This involves goal setting and negotiating what is called a change plan of action. In order to reduce ambivalence, practitioners aim to reduce ambivalence by eliciting change talk. This can be done by asking a series of targeted questions from the 4 following strategies: disadvantages of the status quo, advantages of change, optimism for change, and intention to change. Now I'll briefly provide you with some example questions for each strategy. First, disadvantages of the status quo. What worries you about your weight? Advantages of change. How would you like your levels of physical activity to look in 5 years' time? What are the advantages you can see of reducing your weight? Optimism for change. When you successfully engaged in exercise before, how did you do it? What strengths do you possess that would help you make a change? Intention to change. In what ways would you like your life to be different in 5 years? Forget for a moment how you would get there. If you could change anything right now, what would it be? To wrap things up, there exist a few guiding principles of motivational interviewing that are important to remember, and we are yet again guided by another acronym spelling RULE. R-U-L-E. Resist the writing reflex, understand the patient's own motivations, listen with empathy, and empower the patient. The writing reflex describes the tendency of health professionals to advise patients about the right path for good health. Thinking back to the authoritative therapeutic style, people have an inclination to resist persuasion, especially when they are unsure about change. And it's for this reason, motivational interviewing in practice requires clinicians to suppress the initial writing reflex so that they can explore the patient's motivations for change. U, understand your client's motivations. A client's own reason for change will motivate behavior change, not the practitioner's. Understanding the client's motivations for change, the practitioner will begin to get a better understanding of the patient's motivations and potential barriers. L, listen with empathy. Thinking back to A of our OARS acronym, effective listening skills are essential to understand what motivates the client. And finally, E, empowering your client. Empowering clients involves exploring their own ideas about how they can make changes to increase their levels of physical activity, and drawing upon their own knowledge about what has and has not succeeded in the past.